Good morning, everybody. Thank you so much for joining us today for our grand rounds. I'm Dr. Jill Farmer. I'm the Director of Movement Disorders with GNI, and I have the pleasure of hosting this morning. And so without further ado, I'd like to introduce our speaker this morning, Dr. Stephanie Alessi-LaRosa. She's a board-certified neurologist, and she completed a sports neurology fellowship at the Kucher Clinic of Sports Neurology. Dr. Alessi-LaRosa is the director of the Hartford Healthcare Sports Neurology Program in Hartford, Connecticut, and the program director of the newly established Hartford Healthcare Sports Neurology Fellowship. She's also an assistant professor of neurology at the University of Connecticut and has a passion for educating patients in the medical community on topics of brain health and sports neurology. So thank you so much for joining us this morning.
Thank you so much for having me today. I'll share my screen.
Sure.
All right, so thank you again for the introduction and for having me here today to speak to you all about this really important topic that does require a lot of education. I mean, I feel as a neurologist that I don't think, until I completed my fellowship that I received enough preparation for managing concussion. And I think people do look to us as neurologists to treat this condition and to be able to do it successfully. So I hope you all, can feel a little more prepared going into those visits with your patients and that you take something away from today's talk. I have no disclosures. And we're basically going to go over concussion, a lot about the recognition, how to return folks to play or even to work, as well as their overall recovery. And then I am going to talk at the end about persistent symptoms after concussion, which is formerly and better known as post-concussion syndrome. The objectives for today are to be able to describe the classifications of concussion and the criteria, and to list mimickers of concussion, as well as identifying treatments of concussion and the approach differences when treating someone with persistent symptoms after concussion. The definition I like to use for concussion, as there are many, but this one I think is the best, really, because it tells us everything. So it's really a transient injury, and it causes a complex pathophysiologic response to a biomechanical force that's imparted to the brain. And this results in a functional disturbance rather than a gross structural injury. Now, the distinction of sports-related concussion is this implicit assumption that the athlete and the patient will be purposely returning to a risk of contact. Whereas with somebody with a car accident, sort of concussion, we don't expect them to get another car accident or another concussion another way, although we all have seen those patients. These are some analogies and examples of the biomechanical forces that I do use with patients. So firstly, the brain, sort of sits in the skull, of course, surrounded by cerebrospinal fluid. It's sort of like an egg in a glass of water, whereas if you shake the glass, the brain or the egg is still moving within the fluid. The other example here is with the axons. So axons, of course, run in these groups from the brain to the brain stem, throughout the cranium, and then also into the spinal cord. And it's sort of like string cheese, where it's, can be sheared or stretched or twisted. So you can get the whiplash or rotational sort of trajectory on the axon. So this is my example of what I call a network injury. So if we kind of think of it as traffic maps. So this is the current traffic in Hartford, and everything's green and open and flowing, and no backup. And then I took this traffic map of Philadelphia, and you see a little more red and yellow and orange and whatever in there. And really, this is the concussion, really, where it's a slowed down network injury. It's not that there's structural changes or that the roads are different or something, but it's sort of just congested, slowed down, kind of like traffic. This is the concussion curve, and I use this with patients to explain concussion to them as well. But really, you have a force to the brain. You get an injury or a number of symptoms, and then over time they come down. This dotted line here is what we call the symptom threshold line. Anything above this line, they would be feeling symptoms. Anything below the line, they do not feel symptoms. But there's this portion of the injury at the end where they're not feeling symptoms, but they are still injured. So the return to play or the recovery process really tries to bring out symptoms so that when I clear somebody, I know that they are fully returned back to that baseline as with their pre-injury. And this typically takes 7 to 10 days, up to 2 weeks, we think of concussion. Now, the classification of concussion has evolved over time. It used to be graded. Nobody grades concussions anymore. But what we use, and this is taken from my mentor, Jeffrey Kutcher, who helped write the guidelines on concussion and through the continuum that was on sports neurology back in 2014. And I think this makes a lot of sense, really. So if we think of concussions as, defining them in terms of how certain we are that that's the diagnosis, a possible concussion, probable concussion, or definite concussion. Possible concussion is that there is a list of possibilities, and concussion is on the list, but it's not the most likely. These things would include other mimickers like dehydration, viral illness, migraines, hyperthermia, things like that certainly can mimic concussion and be on the same list as that. So possible concussion is sort of not concussion, but that's on the list. A probable concussion is there's a list of possibilities, and we do feel that concussion is the most likely. And then the last one is a definite concussion where there's no list, it's just concussion, that's the only explanation. So in terms of how we approach management, for a possible concussion, we would treat sort of situationally, depending on what we really think it is, since we don't think it's most likely concussion. But for the other two categories, we would treat them as concussed. So how do we determine which classification to use? This is based really on two things, mainly, the mechanism of injury and the symptom course. So the mechanism of injury is actually really important. I end up getting a lot of details about, did something hit you and then, it was enough force for you to hit the ground after, or were you running at something and then hit it abruptly? What it was the mechanism involved. Because not every hit to the head is a concussion. And I think that's a big point, because I think in a lot of urgent cares and primary cares, I don't know if it's out of an abundance of caution, but standing up into a shelf is not a consistent mechanism with a concussion. So we've got to think about, was it enough of a force to have the brain conceivably shift in the skull? I mean, I think some people don't give the brain enough credit and think it's sort of swishing around in our skull, but it really does take quite a bit of force. So mechanism definitely matters. And the symptom course, it's sort of, I take any symptoms really up to 3 days if they arise within 3 days, but certainly within the first 24 to 48 hours as related to the concussion. And, if somebody had a headache who, it resolves within 12 hours or so and has no further symptoms, maybe that's not a concussion. That might be a traumatic headache or something else. And otherwise, with the next scenario with migraines features, let's say they had light and sound sensitivity, sleep issues, nausea, appetite issues, mood changes, dizziness, etc., where they're hitting a lot more areas than just a headache that resolved, lasting, at least 24 hours or more. That might be a more consistent symptom course for a concussion. So these things really matter. And I think getting a really good history of course always helps us in this situation. So if it isn't a concussion, what is it? Sort of my top 3 mimickers, I sort of alluded to the first one is a traumatic migraine. So a lot of times patients who have a history of migraine, or even if they're, a pediatric population and they have a family history of migraine and they take a hard impact to the head, it really irritates the peripheral nerves of the head or the face. And it certainly gets processed in the trigeminal nucleus caudalis, which then triggers a migraine. And certainly those patients would have a lower threshold for that. So they can go into a traumatic migraine, which, you'll certainly have a lot of concussion symptoms, but it really doesn't evolve into a full concussion syndrome, I would say. So traumatic migraine is a main mimicker. Another one that is often missed is occipital neuralgia. So certainly with a hit to the back of the head, you can get the greater or lesser occipital nerves there. And, it could be from a direct trauma, or even if they've gotten enough of a whiplash or some sort of neck strain, at the suboccipital muscles that can be sort of squeezing around the nerves there. And it's something that maybe we don't routinely check in the office. So even just screening people for some occipital neuralgia can really help out the case. And the third main mimicker is sort of along the same lines, but with a cervicogenic headache. So they can have neck pain, neck strain, neck weakness, that's again associated typically with an occipital headache. But it's really important to screen. Like I do the range of motion of the neck and palpating muscles posteriorly in the neck muscles to just look for a neck strain, which of course can contribute to headaches and even dizziness and other symptoms. So here's some other examples of mechanisms. These are just some good videos that I've sort of gotten along the way. This is a Western Michigan University game. When I was in fellowship, we covered their team. So this is on a kickoff return. This athlete here in the front is the one that we'll be looking at. So he's receiving on the kickoff return and blocking here. And so he kind of gets hit and spun around. I'll show you that again. So he lowers his head and gets kind of rocked all the way to the side, and his sort of limp, he's not really able to catch himself with his arms. So his arms and legs actually were paralyzed momentarily. And he starts to be able to move here as the trainers are tending to him. But he had neck pain. Certainly lowering your head's not a great idea. This is me and my mentor here. I went to the ER with him and such. So, but it was a big mechanism, and we were worried about the spinal cord and et cetera. So that is certainly a mechanism. This is from Twitter, but this is a fighter who I saw after the fact in order to clear him to return to fighting. But this was an injury he had. We're looking at this gentleman here. And he kind of takes a combination hit there. The old 1-2. And he really goes out. So he loses consciousness briefly, but he really has no memory of any of this. So he's got a vacant stare. He starts to get himself together and try and coordinate his arms and legs, but he really falls back over and is really out. So the ref then calls the fight, and the doctors at that event come in. But he recovered fine and went on to fight more. Now, this is a video of a patient of mine whose father gave me the video for educational purposes. So this is a soccer game here. So we're looking at this guy in red here. So he kind of gets pretty shoved, shoved, and at full speed of running, he takes a big impact back of the head. His head sort of bounces off of the field. And then he's just immediately holding his head. So he took a while to recover. He had a lot of rehab needs in terms of vestibular oculomotor type of things as well, but certainly a mechanism. So, recognition is important, right? Because the rule is if anybody has a standout hit during a game or a concussion symptom, that they are removed from play immediately for the rest of that game. And then you can decide what it was or wasn't the next day. So recognition on the field is really important. Again, that vacant stare, really just confused or dazed. Maybe they're not setting up for the next play properly, holding their head, slow to get up. These are all important things. And sort of when I'm on the sidelines, that's sort of my first exam is, how are they getting up? So you really have to be very alert on sidelines. So this is a video, again, highlighting the importance of recognition, because things can be sort of subtle sometimes. We're looking at this big guy here for Cincinnati, and he kind of gets rocked from the side. Now he's over here rolling around, and the pileup is over there. So, you know, most folks would be looking at the pileup. So we've kind of got to keep a broad view and looking here. This guy comes straight at him, and that really rocks him out. So he's over here rolling. And then you'll see he tries to get up. The ref picks up on it, which is great to see. And he takes a misstep there. So we'll see how he gets up. He does take a misstep, very subtle again. So, you know, important. He tries to shake it off. He stuck his head there a little bit, trying to set back up again. And then the ref again comes over to him because he can tell he's not right. And then the athletic trainer comes and checks him out. So other tools for recognition, other than our first exam and our observations, you know, and I do this in the office with every concussion patient. This is called the vestibular ocular motor screening test, or the VOMS test. And it was developed by a physical therapist at UPMC, I think around 2014 or so. And you know, has a lot of evidence and is well established now as a great screening tool for concussion. So it does a number of eye movements and eye tracking sort of examination modalities. The first one is just the regular age test, smooth pursuits, you know, making sure there's no saccadic intrusions. The next one is to look specifically at saccadic eye movements, where they're holding, you know, you're looking at two fingers back and forth, back and forth. You do the horizontals, you do the verticals, and, you know, just again, looking for undershoot, overshoot. And, you know, really throughout all of these, you're asking them, does that cause headache? Does it cause dizziness, nausea? You know, because of course it shouldn't. So if it's symptomatic for them, then that would be an abnormal result. The next one is convergence. So you do the near point convergence and trying to make sure it's within 6 centimeters. But, you know, if it's beyond that, that would be taken as abnormal. The vestibulo-ocular reflex, so looking at a fixed object, typically we use a tongue depressor with a little X on it, and really just looking at that and doing horizontal VORs and vertical VORs, and again, asking dizziness, headache, nausea, etc. And then the last one is called the visual motion sensitivity test, or the VOR suppression test, because they have an outstretched arm and they're kind of rotating with their upper body. So they're not really doing a VOR, but they're sort of moving in space, and that motion sensitivity part of it can be very distressing for an acute concussion, and you know, causing a lot of dizziness or nausea, etc. So you know, as neurologists, we like doing eye tracking tests and eye movement tests, and I think we're, you know, very, you know, more equipped, I think, to pick up on these things. So I really love doing this clinical test. I think it's a great objective tool to have, and I do it on the sidelines as well. Another well-established tool is the SCAT5. They've had a series of different, you know, concussion sideline tests, such as the SCAT5, but we're up to 5 now. And so this is pretty comprehensive. It looks really at history, a symptom checklist, mental status, balance, motor, you know, looking for focal findings, things like that. And so, you know, that I think is a good test, because it looks at not just the cognitive or not just the balance as some other tools do. So this one's a bit more comprehensive, so it's a very good screening tool. Now, this is like the famous symptom checklist. And so, you know, it's a 22 symptom checklist. I say famous because that's really where all the research has come from, using these 22 symptoms. And we sort of use a total symptom score, like how many number of symptoms out of 22 do they have? And then the symptom severity score, which is, you know, out of 6, adding up the actual numbers of each one for a total of 122. So essentially, you know, that you can read the list here, that some of them are very vague, like, oh, they're just feeling slow, or just, you know, difficulty with things, you know, and just don't feel right, kind of thing. So So it can be very vague. I think some high school students sort of wake up feeling a few of these things, or maybe some of us do as well. I don't know, but so it's sort of limited, and there's a ton of overlap with other entities. So, for example, if somebody is having a migraine, not a concussion, but a migraine, they might have headache, nausea, vomiting, light sensitivity, noise sensitivity, irritability, feeling fogginess, and having visual problems. So, I mean, is that a concussion? No, because you still need to get your history and figure it out that way. So it's sort of limited. Another example is if somebody just doesn't sleep well the night before. So you might have a headache, you might have fatigue, trouble falling asleep, loss of sleep, drowsiness, irritability, feeling slow, difficulty concentrating, difficulty remembering. So again, that's even more symptoms than for the migraine, just for not having good sleep. And this one's just for fun, but after eating a big meal, okay, you might have nausea, fatigue, drowsiness, feeling slow, or difficulty concentrating. Now, this is the schematic that I use with my patients. I have it as a handout in the office, and I use white erase boards in my office, so I sort of draw these things out as well. But really, it goes back to that concussion curve where you get a number of symptoms, and over time, it improves. Now, there's sort of these different phases up here. So the first phase is the acute rest phase. The second is the relative rest. And then the third is graduated exertion. Now, the acute rest phase is sort of, it's an optional phase, I would say. Not everybody requires acute rest, which is where you're kind of doing nothing. We do not do cocoon therapy anymore. We sort of go by symptoms. So sometimes people are so symptomatic that they really can't do anything but sit in a dark room by themselves without screens. But that's not always the case. So if people can do some things around their house or do some screens or some school or some work, whatever, that's sort of a relative rest period. So, the acute rest phase, if that's what they need, I will, let them do that for the first 2 days. I'll go over why only 2 days, but 2 days is sort of the cutoff for that. And then we start to try and get them back on a normal routine now. So that's sort of how we get from acute rest to relative rest. And then the graduated exertion is with the return to play process. So that always starts with cardio, low intensity cardio. I prefer the stationary bike because it doesn't jostle the neck. If there's a neck strain involved, that's usually the best way to start out. Just to give the brain an idea of what it is to get their heart rate up again. So you do some cardio, some interval cardio even. Next step is agility. That's moving in space more, doing squats, doing body weight things, sort of changing their position. Again, making the environment a little more complex that way for the brain. And then adding in some weight lifting would be the second portion of the agility. And that, of course, raises like the Valsalva and raises the pressure in the brain. So that's another challenge to the brain, when getting back to a sport where there's maybe explosive movements like that. And then the next is sport-specific drills, or the other, way I call that is non-contact practice, depending on the sport. And then the final step is the full practice or a contact practice, again, depending on the sport. So as we're going through each of these phases, the symptoms should continue to be coming down. You really want to start the cardio phase, somewhere around the symptom threshold line where they're basically asymptomatic. And then you kind of progress. And then as soon as they're able to tolerate everything without bringing up symptoms, then you know that you are, fully back to where they started and they're safe to return to play. So here's a case for concussion. This is a 9-year-old boy who was on the office, and he does a sailing program, and he was struck in the head by the boom, which is this portion here that kind of swings, right? So that's a common injury. I take care of a lot of Coast Guard Academy folks as well, and so they're always sailing, and booms are a big problem. So this was the case with this 9-year-old. Now, he had no loss of consciousness, but he did have some amnesia after the hit, and he really didn't recall some of the events afterwards. He had initial headaches and nausea, and I saw him first on day 3 of the injury, and he was feeling pretty asymptomatic. So I said, okay, well, I have a bike in my office, and sometimes in this situation, to determine are they concussed? Are they not concussed? We might do a low intensity workout. So we did a little bit of an in-office workout. He didn't have real symptoms that he mentioned in terms of headaches or feeling dizzy, but after we did, a brief exertional test, I re-examined his VOMs and some balance, and he did have worsened convergence. So his convergence was in a normal range initially, and then it was out further after the exertion. So that was a sign to me. And so we really managed him with a more gradual return to play process. Again, just going to start with the light cardio and then start that process, as his symptoms tolerate. So I saw him again on day 10 of the injury. And, intervally, he actually went and ran an all-out running race for a half a mile. And he did get a headache and nausea. So he's a 9-year-old. So, they have a hard time modulating their activity level. And it is very hard to control that. So he's sort of an all-out kid. So he did that. He woke up the next day feeling fine, but it definitely stirred up some symptoms when he did that. So I did another in-office workout with the stationary bike, and this time we did intervals. And on the second interval, it did cause a headache and some nausea. So then we progressively cooled him down. We did his exam. His headache had resolved by then, and the nausea was improving, and his convergence got closer than the pre-workout convergence. So that to me is sort of a training effect. That's like, okay, now he's ready to keep going because his exam and stuff had actually improved with the exertion. So we wanted to keep him at the cardio with interval step because he didn't fully get through all 3 intervals there. And then progressively get back to soccer was his next sport. He does lots of sports, this kid. He does, triathlons even and all this stuff. So anyway, his next sport was soccer. So that was our plan to get him back to that. And he did great. He got back, no problem. And that was a couple of years ago. So he's done great. Now, in general, I always go to my basics, okay, in terms of treating concussions and treating even the persistent symptoms after concussions. Because as we know, the brain likes hydration, routine sleep, 3 meals a day, and physical activity. So, a lot of people, not just kids, a lot of adults, and I think some of us may be guilty as well, we don't hydrate enough. We don't get our 64 ounces of water. Maybe our sleep is broken up, not falling asleep or staying asleep, not waking up refreshed. All of those things are important. And, we're all running around. So it's hard to get 3 meals a day. But of course, the brain likes that routine in addition to some physical activity, which we have more and more research saying that even low intensity cardio is just great for your overall staving off dementia and just overall neurologic brain health. So I try to maximize these as much as possible, because some of the advice patients get is to do nothing for a week or 2. Even still, that's the advice sometimes out there. So people are off their routine. If you take an athlete and you just rest them, not even an athlete, if you take somebody who just likes to be active on a very regular basis and you rest them without a head injury, you're going to start throwing off their sleep, their mood, everything else is going to kind of follow and snowball, and they get headaches from that, So it's really important to try and get the brain back to at least feeling a little more normal and simulating its normal condition as much as possible. And as a principle, I really use as least prescriptions as possible, and certainly the lowest effective dose possible. A lot of athletes or a lot of, even a lot of our other patients these days just don't want to be on prescriptions. I think there's a big, I don't know if it's a stigma, but it's just, they just don't want to take in pills. So, which is fine, obviously then we're not dealing with side effects and the other mess that can come of that. So, and a lot of them, because they're medication averse in general, they really are sensitive to medicine. So you really need to start low in those types of patients. But, really that's sort of my principle for recovery purposes here. Now, other advice that's really important, and I kind of alluded to this already, but, if patients are told to, don't do screens and don't do lights and don't do this or that, just sort of as like blanket rules, okay, not even, specific to them. they just begin to decondition themselves to lights and screens and, you know, life really. So, so I try to avoid avoidance is what I tell my patients. You know, really just try to follow your symptoms and use your symptoms and take breaks when you need to. You know, and that's in terms of physical activity, again, to lights, to sounds, to, you know, the office, to, I don't know, whatever complex environments, things like that are really important to not avoid. And it can prolong the recovery and make it really difficult when we try to reintroduce those things. So the other thing here is that rest is not best. So there was a randomized control trial that was done by Thomas and colleagues in 2016 that compared 2 days of rest to 5 days of rest. And the 5 days of rest group had a prolonged recovery. So we really take 48 hours as, you know, that's our cutoff. You know, you can take naps, you can do all kinds of stuff for the first 48 hours, but after that, you can always do something. And I encourage people to cut the naps out at that point, get back on their sleep routine. You know, they can use melatonin if their brain is sort of like, when's the bedtime now kind of a thing. You know, so I try to just really get them back on a normal routine at that point and going for walks and trying to mimic some level of activity again. So here's that sort of schematic for concussion again, but I've added in a few other scenarios. So this one is that there's a force, you know, significant number of symptoms, and then it sort of improves and then gets to a point where it sort of plateaus or sort of does like good days, bad days, kind of a fluctuating thing. And that's more the persistent symptoms after concussion or post-concussion syndrome. This other graph is sort of like basically that they have a bunch of symptoms and they're just getting worse and worse and worse and worse and worse and worse and worse. So this is not following the concussion curve at all. And that's not a concussion. That would be something I'd be worried about, a bleed or something else structural going on. So they would get an immediate CAT scan if I saw them in the office several days out from their injury without having turned a corner yet. So let's move on to the persistent symptoms after concussion. So again, concussion is a transient injury and it resolves typically within 2 weeks. The concussion itself resolves within 2 weeks, but the symptoms may persist and it's for other reasons. Persistent symptoms after concussion or post-concussion syndrome is not a long concussion. It's a separate complex disorder and it requires a very different approach to management. What do I mean by that? So let's take these 5 symptoms here. Typical symptoms, right? Headache, sleep, concentration, memory, depression. You start to, you know, make these connections where everything starts to make each other worse. Okay, so sleep is then making the headaches worse, which makes, you know, sleep also makes memory worse. And then memory gets them more anxious or depressed, you know, and then again, anxiety, depression, making the sleep worse again, you know, and everything sort of comes back around to concentration, headaches, you know, memory, all this stuff. So, you know, and there's a list of other symptoms as well that can be, you know, roped into this, but really it's this web. So now the symptoms have taken on their own life here. And it has nothing to do with the brain or brain injury. This is just the symptoms need to be addressed and put away. So in the office, I tell patients, look, when this is happening, you know, I can't just treat your headache because your headaches are happening because of all these other issues. You know, again, we got to talk about sleep. We have to talk about mood. You know, maybe they have an adjustment disorder that's going on and needs to be addressed, you know. So this is stuff that we sort of have to take this comprehensive approach in order to move the needle and help them turn the corner. So it's not enough to just pick one of these things. You have to really look at the whole situation. So there are factors, you know, pre-injury factors that can prolong recovery. These are things like migraines, a learning disability or ADD, ADHD, anxiety, depression, and other psychiatric or personality disorders, you know, borderline personality disorder, a history of PTSD, you know, these types of pre-injury things that can prolong the recovery. And then the post-injury conditions are things like neck strain, the vestibular oculomotor issues, occipital neuralgia. And these can all come with the concussion initially, but if they're not addressed, you know, the mechanical injury that's happened, that's not addressed, that's going to lead to a prolonged recovery. And again, I mentioned adjustment disorder. If this event has now made them fearful of driving or fearful of cars or fearful of public places, I don't know. They don't have the coping strategies to deal with things and to deal with their symptoms even. People just feeling symptoms is stressful, and then it goes straight to anxiety. So, they need some psychotherapy for that, right? And so then the next one is sleep issues. So again, if they're not falling asleep, not staying asleep, I don't see how we're going to get their headaches under control. You know what I mean? So we have to look at everything. Autonomic dysfunction is another thing that frequently comes with concussion. And that's sort of just even maximizing their hydration so that they don't feel a variation like an orthostatic change when they get up quickly. That can, of course, improve their headaches as well because it's extra hydration for the body. And I always have people not just water, but add electrolytes that have sugar and sodium in it. Not things like, Noon tablets or vitamin water, that kind of stuff doesn't have the hydrating electrolytes that we're talking about. So, and really just making sure they're not resting too much or even pushing through their symptoms too much. There's sort of the opposite extreme patients where the patients that just say, oh, forget it, I'll just push through. I just got to get back to doing everything, and those people are going to take a long time. So, so it's sort of this balancing act between too much rest and too much activity, basically, and finding that sweet spot where they're actually listening to their symptoms and rehabbing that back. So other sort of, things to mention about treatment and management is, again, it has to be a comprehensive approach. You have to identify all of the factors. There's no cookie cutter protocol that's effective really when this situation happens with the persistent symptoms after concussion. So, I have, a lot of colleagues and a lot of, other specialists that treat concussion or post-concussion syndrome right off the bat with like a TCA. They're getting amitriptyline or nortriptyline or something. Maybe they don't need that. Maybe they don't have migraines, or maybe they're not having a sleep problem. I don't know, but there's no cookie cutter protocol. So TCAs are just like automatic beta blockers, that kind of thing. That's not really a thing. That's not something that there's a protocol for. It really has to be this, like, let's talk about what the issues are and give them an individualized plan that's comprehensive. And again, some folks go straight to neuropsychology testing. And again, it has a role. All of these things have a role, but they're not for everybody. So that's what I really want folks to think about when you're seeing these patients. So here's, some other advanced testing that we can do. For MRI, I do susceptibility weighted images. I find that those are better than the GRE sequences in terms of looking for microhemorrhages or any other structural issue. And diffusion tensor imaging, or DTI sequences, can be really helpful too in determining, any axonal issues and changes there. In terms of neuropsychology testing, like I was saying before, it can be very helpful, especially if a patient is, despite, handling their stress or their sleep or their pain or their mood, which typically brings in the cognitive issue. If that's all been dealt with and they're still having a cognitive complaint, then I always send them for neuropsychology testing. But, really, it can be very helpful in finding, anything that's an uncontrolled mood disorder or psychologic or psychiatric issue that really needs more focused or more aggressive treatment if it's still uncontrolled. And then that might be a factor for their memory issue. And again, things are typically explained by a mood disorder, the stress, having pain in the body. These are things that are just going to distract the brain so that they can't focus and they can't perform cognitively. And, a 3 or 4 hour test is pretty onerous for a patient who's already struggling. So it's not something that I'm like eager to have somebody do. I try to really maximize them in these other ways before subjecting them to that. Other therapies, of course, include, like I mentioned before, cervical physical therapy. And, there really are differences in the approach. Certainly all physical therapists are not created equal, just like with physicians. But, there's ortho techniques and ortho approaches to the neck that are different than like a neurologic approach, where maybe they're looking more at, cervical proprioceptive things or the headache aspects of the neck. And so that's important to identify. Vestibular and oculomotor physical therapy if they have any of the issues on the VOMS test, or if they're having vertigo, is a great move. And cognitive rehab with speech language pathologists can be very helpful as well. You know, doing their working memory sort of in terms of them getting back to work. If their working memory isn't right, you know, they can get tools and strategies for all of these things as well. And then, like I mentioned before, the psychotherapy or cognitive behavioral therapy for any anxiety or depression that's kind of impeding their physical symptom recovery is really important to address. So I know I've said this a lot, but really comprehensive plan is the way to manage post-concussion syndrome or persistent symptoms after concussion. You want to screen for, you know, things like rebound headaches from over-the-counter medications, you know, and breaking this intractable daily headache with an NSAID course or prednisone course, and just see what comes next. You know, TCAs won't break status migrainosus, you know, so, you know, really think about what's going on here. And resting, you know, is really only, again, recommended in the first 2 days of the concussion. So if someone's coming to you with persistent symptoms after concussion, you know, they definitely do not need more rest. So, you know, and unfortunately, a lot of, you know, folks out there are saying, you know, oh, you just need more rest. You just need more rest. And this, I mean, that's a vicious cycle. The more rest thing is a very vicious cycle. So trying to reintroduce some more activity is important. And again, not all physical therapists are created equal. Like I said, just with everybody else in medicine, it's an art, and they have varied training, varied techniques and interests. So I never use concussion for my diagnosis to a physical therapist. I like to say they have cervical strain, they have vestibulocular reflex, you know, deficits, they have convergence insufficiency. You know, I'm very specific about what I need from them from a rehab perspective. And I think it helps a lot because, you know, to say concussion, I mean, that, like I'm telling you, it could be a number of rehab needs with that. And that probably makes their eval longer and, you know, a little more scattered. So if you can identify what you need from them and use those diagnoses instead of just concussion or post-concussion, you know, you might get that patient further quicker. And, you know, I always say, you know, I have patients who see me after even a couple of years of their injury. And just because they've tried physical therapy for their neck before, I'm not going to assume that they've reached their full rehab potential. You know, I really like to work with the physical therapist in my institution because, you know, if I'm finding something on their exam, I'm thinking it wasn't addressed or something was not fully addressed about that issue. So, so just because someone says, oh, I've done PT, you know, for 3 months, honestly, I would send them to somebody who I can help collaborate with and get a different result. And that's important to keep in mind. So I'm going to finish with a couple of cases because I think, you know, the post-concussion syndrome is something that we see quite a bit of. Our residents see them in clinic, and it can be daunting because someone says, oh my God, I've had this thing for 2 years. Like, what do I, you know, can you help me? You know, and it can be a little bit daunting. So here's a couple of cases. So the first one is a 50-year-old female. She's a freelance writer. Her injury was December 2019, and I didn't see her until June of 2021. She had fallen in a snowstorm and hit her head to ground. So certainly a mechanism, falling from a standing height. And she had an initial headache right away, went to bed, and her persistent symptoms were headache that were sort of the phenotype of migraine as well as tension headaches, nausea, irritability, forgetfulness, dizziness, lightheaded when standing, difficulty with writing for long periods or even tolerating car trips. She had sleep issues, exercise intolerance, and she used to go to the gym 6 days a week. And now she can really just garden, walk, some yoga. So she's not really living the life that she wants to live. And she had some pre-existing anxiety and migraines and ADHD, actually. So she had a number of factors that would lead her to a prolonged recovery. And overall, I always ask this sort of subjective question, but, you know, how are you feeling if 100% is how you felt before the injury? And you know, she said she's at 80%. She was still writing. She's just not doing as much as she would want to. And clearly the rest of her facets of her life were not where she wanted to be. So I, you know, gave her a course of naproxen because she was having headaches every day. So I said, okay, take naproxen, you know, twice a day for 5 days. Let's just try to break a cycle. And I ramped up her hydration significantly. I said, take 80 ounces of water, electrolytes in the morning and at noon, and just really take breaks as needed and don't push through symptoms. Listen to your symptoms when you need to take breaks, and you'll be able to sort of pace yourself through the day better. I did an MRI brain because no imaging had been done to that point. And basically, I saw her 2 months later, and she felt 95% back to her baseline, which I don't know if anybody's ever 100%. I don't feel 100% some days, so 95% is pretty good. She's riding as much as she wants, hydrating well. She told me, you know, Gatorade or just electrolytes changed my life, you know. So she had no more dizziness, and she wasn't pushing through her symptoms, and she's just living a much, much better life. Now, this case is a lot more complicated. This is a 45-year-old woman who's a CNA. And so her injury was on 2/9 of 2021, and I saw her within a few weeks on 2/26 of 21. She had a work-related injury, but she fell and slipped on the ice in the parking lot at her job, and she landed and hit her head to ground. So she had an occipital headache, migraines, neck and back pain, dizziness, sleep issues, speech issues. She couldn't actually speak in full sentences. Fatigue, nausea, difficulty walking, mood changes, etc. Her exam had a lot of functional overlay. You know, she had a gait thing, she had some motor, you know, issues that were functional, and she had trouble even following commands at all during the exam. You know, language was off, stuttering speech. You know, her range of motion was decreased, her neck strain, muscles there. She had muscle strain. So we had a CT scan that was done on the date of injury that was negative. So it was a lot to unpack here, you know, and just looking at the exam and looking at her was a lot to unpack. So she, I had her do some psychotherapy. We encouraged that from the beginning. I gave her hydroxyzine. I like that sometimes for the sleep and anxiety that she was experiencing, and to continue the physical therapy that she was already in, and to do some decrease. You know, she was taking way too many over-the-counter medications, and we did a prednisone course to help with that. And then I ramped up her hydration as well. But of course, the work comp system, as it does, delayed her treatment, particularly with the psychotherapy. You know, they don't want to cover that one. That's a tough one to get, but she really had no history of any anxiety before this. So it was directly related to this injury. And she had such a severe stress response that she couldn't really do the physical therapy. I mean, how if she wasn't following commands in my office? I don't know what she's doing in physical therapy. So I told them, hold off PT, because I didn't want her to waste all those sessions. They only give her so many sessions. I said, well, hold off until we can get the stress under control. You know, I tried a number of medications. She was having flashbacks in her sleep. I mean, she really had a PTSD response to this injury. So I had to push real hard, you know, to get the psychotherapy, but I said there's just no path forward physically until that can get under control. So by June, so I saw her at the end of February. By June, she had been in psychotherapy. She was now speaking in full sentences, and was not requiring assistance while walking because of the psychotherapy. I then returned her back to physical therapy because I felt she could actually benefit from it then, to work on these other physical issues. And then by July, she was back to work part-time, and she had some restrictions. But, you know, later that year, she sort of plateaued and couldn't really get past a 4-hour shift. She was losing weight very rapidly. Her stress and anxiety and the PTSD was really ramped up from the workplace. So I actually took her out of work at that location, and I said if she could be somewhere else, that she would do fine. And by January, she completely improved. So even just in a few weeks of getting her out of that work situation, she returned 100% and was working full-time somewhere else in the same role. So if you do the work and you think about the case and you kind of collaborate with as many people as possible, you can really make these people's lives so much better. And that's really the reward here. So to wrap up with some take-home points, you know, not every hit to the head is a concussion. Really think about the mechanism and the symptom course, and there's always something you can do differently than was previously tried. particularly with the non-pharmacologic things, and just going back to basics, like I said, with the lifestyle modifications can really be impactful. And treating with, post-concussion syndrome or persistent symptoms after concussion gives patients their life back. And it is very rewarding because it's an invisible condition. I find too with the workers' compensation and car accident folks, or anybody who has a lawyer, that there's this additional stigma to them, but they really just want to get back to work. I rarely come across a malingering situation. I just think that they haven't been given the opportunity to improve in a lot of cases. So with that, thank you so much again for having me. And this is my contact information. I'm on Twitter, that's my email, and happy to take questions and comments now.
That was fantastic. Thank you so much. We do have some questions coming through, and I'll go through them. Just for my own question, for patient 2, how receptive was she to the psychotherapy part of things?
Good question. She was actually a woman from the Caribbean. And so it was difficult. I will say it was difficult. But I think once she met with the woman and they did have a good rapport, she trusted me at that point, because I really was taking, a hard stance on things with work comp and really advocating for her. So I think that having that rapport and that trust really helped her to just kind of do what we needed, and get it done. So it does make a difference. But yeah, no, it was not a straight and narrow kind of path on that, but yeah.
No, definitely not. Okay, so some questions coming in. How to approach EEG changes like focal slowing with immediate post-concussive seizure?
Good question. So, typically I don't overreact to the traumatic seizures, because again, they're sort of provoked. Okay. So I don't necessarily put them on medication. I think we do, obviously you'll do the MRI, you'll look at what the focal thing might be, and sort of work it up that way. But, it sort of, let's make sure there's nothing underlying here, that made that threshold lower. But if it's really just a transient thing, you might just repeat the EEG. It sort of depends on the situation, the history, the characteristics, and all of that as well. But yeah, a tough question. But I think there's no clear cut answer. It's just sort of sure, using your best judgment.
Have you seen patients who have had many concussions, say from college football athletes, develop symptoms of post-concussive syndrome years after the fact?
Absolutely. So I have patients who, they had a career in football, or they had a career in ice hockey or something like that. And, even pro, semi-pro, whatever, and took a number of hits in those days, and then see me a couple, even decades later, saying I have memory stuff, or I have personality changes, or, I'm depressed or whatever. And their concern is, do I have CTE? So CTE is not a diagnosis you make in a living person. So I always educate the patient that, if you have or haven't, if you do or don't have it, it doesn't really matter right now, because there's no treatment for whatever that is, right? That's a diagnosis after you're gone. So I treat what's in front of me. I'll do a neuropsychology eval. I'll have, a psychiatrist kind of take a look at things, medications, see what we can do. We treat what's in front of us, with that type of scenario. And it's hard, because there's still absolutely not clear literature that says that, repeated hits to the head then causes personality issues or mood changes or memory changes, and then causes CTE. There is nothing with that whole cause and effect continuum at this point. So it really is, we're just kind of going with what's in front of us. And a lot of times, I will say, in those athletes who had a career and then retired from their career, that's a big lifestyle change to then, have this life of just, I'm an athlete, I have a team, I go in every day, I work out every day, I make a lot of money, I don't have financial problems, I don't have anything. Then, you take a step back from that life, that can also trigger stress. Okay. It triggers, they have a life of chronic pain because their bodies have been beat up. They're on maybe opiates. They're just, there's a lot of factors to that. And it's really not enough. I think it's almost small-minded to really pin that on the head injuries. I just don't think we have the data for that.
Um, for as far as mechanisms for persistent symptoms like headaches, do you think it might be caused by an increase in CGRP? Have you tried Nurtec or Ubrevely?
Yes, I try all of them. I sort of, of course, insurance asks us to start with some triptans and whatever. So we kind of play the game a little bit. If somebody's having, they really have a phenotype of migraines, and they're not on a daily basis. Of course, you can't give too much abortive at that point. But I do things even for prevention. I do a lot of vitamin B2, a lot of magnesium oxide. Athletes love that stuff. Okay. And obviously there's great literature on that. So, working with a preventive, and I definitely use Emgality quite a bit. I use all of the CGRPs and as much as possible.
Do recovery times change if it's repetitive concussions?
Good question. That is a myth, so it's not really, if you've had a prolonged recovery, it doesn't mean that your next one's going to be prolonged. I think a lot of times, again, because especially if it's from, a neck strain or just something mechanical that was not addressed, and oftentimes it is that simple, honestly, then you put that away, the next one goes back to being a normal, 2-week ordeal, 1 to 2 week ordeal. So it doesn't necessarily mean that it will be completely progressive. And in the terms of like another myth I find too is, they've had 3 concussions or 5 concussions, did they retire? It has nothing to do with the number for me. It really is, have they recovered in between each concussion? Or are they accumulating symptoms as they go? And that's obviously, those are different scenarios, but a retirement decision is a sensitive one. It's one you really want to take care and attention to. But good question. Yeah, it shouldn't, lower their threshold down the road or anything.
Is there any role for functional MRIs, if not from just research, but maybe diagnostic purposes?
So for right now, it really is just research. It doesn't change our management at all. It still, again, remains a clinical diagnosis, clinical management, and, functional MRI, I think has some promise. There's quite a bit of radiographic biomarkers that we're looking at, and, blood serum biomarkers, CSF biomarkers. We're looking at tons of biomarkers these days, saliva even. And it just hasn't really hit to the point where it's making a clinical decision for us or helping us with that. So still not.
In therapeutic approaches, non-pharmacologic, aside from physical therapy, have you found that osteopathic manual manipulation, whether it's craniosacral therapy, anything like that, might have a role or be helpful?
Yes, I definitely find that because the soft tissue of the OMT can be really helpful, I think. And I have had a number of athletes that did go that route and do very well. Certainly, I don't recommend chiropractors. We're all, I think, on the same page as that. But OMT is great, for the soft tissue type of things. Craniosacral therapy, I think the therapy techniques themselves are great. But sometimes, I don't know why this is, but I do find that the therapists start to give the patient other information that's sort of a little bit out there and a little bit like, yeah. So that part does a little bit of damage. So that's the part where I don't love the craniosacral therapy because of that, where then the patient gets confused and things. But the techniques, I'm sure, are fine. I think they do have a lot of value, especially with the suboccipitals and other releases that they do. So it's just kind of a challenge I have, with that.
And I think that would be like looking for osteopaths other than someone who's just certified in craniosacral therapy or things like that, to avoid some of the other information. One last question. And as far as return to work issues, you've laid out the approach that you've taken comprehensively when other factors are playing a role, but when they're not helping and you've done the other factors, like what is the role for either taking someone out of work or working with their HR or that kind of thing? Yeah.
I mean, it sort of kind of evolves on its own. If the patient is like, I've been a patient for like, 2 years before seeing me and I'm trying new stuff, sometimes they just get burnt out from the process, and some of them just like, I'm done. I just want to do what I can do and that's it. And that's fine too. I just like to work with the patient. I try to, take my lead from them. sometimes if I feel that, they still have, if they're still complaining of neck pain or they're still complaining of, something, I might go the pain management route and refer them out to pain management. I try to give them something that might give them tools, if it's not going to be from me as a neurologist, maybe there's something like that. But sort of at the end of the road, it kind of just naturally kind of comes to it. And, I work with their HR. I see, what jobs do you want to do? There's probably other things that they could do. But it's a decision to make together, I think, with the patient, and just trying to be, as supportive as possible.
Mm-hmm. Well, thank you so much for the great presentation, answering all the questions. We really appreciate it. And this will be recorded. So it has been recorded, and it will be posted on our website. So anybody can go back and refer to it should they need. Thank you again. Have a wonderful weekend.
Okay, thank you all so much. Bye now.
Bye-bye.